Okay, great. Yeah, we'll spend 25 minutes on the presentation or so, and then 10 minutes for Q&A. 35-minute block here. Okay, great. Well, thank you, everybody, for being here today. I just wanted to say, first off, thanks to Professors Jennifer Hooker and Charlene Skidmore for their stewardship of the honors program. Thanks to all my friends that are here today, various Drake professors, fellow students and colleagues, and even a few from the Des Moines community. And then obviously thanks to Ruth Thompson for filming today's presentation so I can share it with other people who are not able to make it today. In the back over there, there's cookies if anyone wants any. And also a quick thank you to anybody who helped fight the tax bill that would take away health care from 13 million Americans. That looks like it's going to be approved by the Senate today. So thank you for your efforts in that regard to those who did that.
Susan Collins just rolled. NBC now reporting Susan Collins just rolled for it.
Yeah. Well, with that underway, we will now move into the discussion today. Today, my topic is finding policy solutions to address social determinants of health in the United States. And so, basically, healthcare is a really important part of our day-to-day lives. Ralph Waldo Emerson once said that the first wealth is health, basically meaning that more than money or anything else, our health is the #1 priority in our lives because it allows us to go about our day-to-day lives and pursue our dreams. And so, obviously, in recent years here in the United States, there's been a lot of debate and discussion around what I call the medical determinants of health, meaning health insurance coverage and all that stuff related to the Affordable Care Act. But today what I want to talk about is the social determinants of health, which is a wider range of factors that affect health care that include the medical determinants, but it goes farther than that. So, for my thesis, I looked at 3 social determinants: income, neighborhood, and race. And basically, I'll lay out a few of the ways in which those are associated with the health disparities we see currently in the United States. So first, there's a 2013 report from the Robert Wood Johnson Foundation, and it found that American children in poor families are twice as likely to be overweight or obese as children in high-income families. And then when we look at the neighborhood variable, I like to use the term variable to refer to the social determinants. It's a little more concise, so just so you don't get confused. When we look at the neighborhood variable, the report found that the life expectancy rate for babies born in Washington, D.C. was 77 years, which sounds impressive until you look at the neighboring counties like Montgomery and Fairfax, where the life expectancy was 84 years and 83 years in Arlington County. And then, moving to the race variable, the Centers for Disease Control and Prevention says that in 2015, non-Hispanic blacks experienced 11.3 infant deaths per 1,000 live births, compared to only 4.9 infant deaths per 1,000 live births for non-Hispanic whites. So we see that there's more than double the infant mortality rate for blacks than there are for whites, which is mind-boggling, I would say. So if you refer to your handout now, having kind of just laid out there briefly the relation of the 3 variables, income, neighborhood, and race, to the health disparities we see in the U.S. If you look at your handout, I have here 2 theoretical accounts that kind of help explain how these social determinants operate. The first one looks pretty simple, but I'll explain it. The top bar, a half circle thing, is the economic and social opportunities and resources. Basically, what I'm referring to is the income variable. So that's on the top. And then below that is the living and working conditions in homes and communities. That would be the neighborhood variable. So you see that the income variable is obviously above the neighborhood variable because the income you have tends to kind of dictate what kind of neighborhood you live in, as I'm sure any of you who bought a home before would know. And so both variables are on top, the income and neighborhood variables, but then they shape they shape the more immediate variables that we think of when it comes to health, like medical care and personal behavior, like what kind of food you're eating, for example. So income and neighborhood, they're both influencing these more immediate influences of our health there, leading to health outcomes. So that's the first figure. And then we move on to the other one. This one focuses on the race variable. Now this one, there's a lot of words in here, but basically the point is that race works in two ways to affect health. One is because of its association with income. On average, statistics show from like the Economic Policy Institute, for example, that African Americans tend to have lower average incomes than whites. And as I'm getting to here, higher income generally leads to better health, but I'll get into that in a moment. But the other way is that race has its own health effects because of racism, basically. On the top, we have institutional forms of racism, what we kind of refer to as systemic racism a lot these days. And then on the bottom, individual level forms of racism. So, race, two ways. One, because of associated with income, and two, because of racism. That's the two ways that race variable basically impacts health and health outcomes. Okay, so that's the review of the theoretical accounts, just to give you a little bit of the broad view of things. Now I want to go through each of the variables, starting with income, then to neighborhood and race, to kind of show the real world workings of how these variables end up contributing to health disparities. So, starting with income, there's what we call a socioeconomic gradient of health, which sounds fancy, but basically all it means is that it's like a sloping thing where basically lower income folks will have worse health than those above them, and then those folks will have less health than the folks above them, etc. So like someone who's extremely poor will be less healthy than a low-income person. Someone in the middle class will be healthier than a low-income person, but a richer person will be healthier than the middle-class person. So it's a gradient. As the income increases, health outcomes tend to be better. And one of the ways this happens is through education. So, according to the College Board, I found on their website, they write that, quote, the typical bachelor's degree a recipient can expect to earn about 66 more during a 40-year working life than the typical high school graduate earns over the same period. So there's obviously significant earnings that come with a college degree, as we probably all know from being here and paying for it. So the idea is that with a higher education, you'll be earning more income, and then as a result of having a higher income, you'll have more resources to facilitate quality health. And indeed, there's data from the Department of Health and Human Services that backs this up. In 2006, it found that men aged 25 without a high school diploma had a life expectancy of 47.1 years, while those with a diploma were expected to live 51.4 years. Those with some college education, a little bit higher than that. And then those with a bachelor's degree were expected to live 56.4 years. So that's nearly a 10-year gap between those men who had a college degree, those men who had a college degree and those who had a high school diploma. So moving on into another way in which income makes its health effects felt is through stress. So, by the way, it's a very stressful event, so just to break the ice a little bit. But basically, so I'll start with this quote from David Blaine. He wrote in his 1995 article on social determinants of health. He wrote that, quote, occupations characterized by high demands and low control, or effort-reward imbalance, appear to be associated with poor health, particularly in relation to cardiovascular disease. And so basically it won't come as a surprise that what he's talking about, those occupations, tend to be jobs that are low income, that pay low wages, and that therefore lower educated workers. To kind of follow up on this, the Robert Wood Johnson report said, quote, less educated workers may hold jobs that are demanding but offer fewer opportunities for autonomy. These types of jobs have been associated with adverse health outcomes, including heart